I'm Dr. Vivek Jawali of Bangalore, India. I am the chairman of the Cardiovascular and Thoracic Surgery Council of Fortis Hospitals of India. And here today we have a guest from Hungary. Can you kindly introduce yourself so that as my surgeons would know you?
Thank you. My name is Szolnoky. I'm the Chief of Adult Cardiac Surgery of the National Heart Center of Budapest, Hungary. I'm actually the chairman of the Hungarian Society of Cardiac Surgery as well. And this is the first time me coming here in India. I'm very impressed by the kindness of the people, the open-mindedness, so it is a big experience for me. So thank you for inviting me.
It was intention today to discuss with you two things. An Indian-made pericardial bioprosthesis, which is not really made by many countries in the world. It has, as you know, the desirable design, profile, ring material, tissue treatment, pericardial valve, and the newer generation valves are actually giving us a one size bigger size. And the second topic was to understand issue about minimally invasive and robotic-assisted valve replacement, valve surgeries, and also the understanding our philosophies about the age at which we can put bioprosthesis, the philosophies about the correct lifetime management policies, etc. So to begin with, let's talk about your philosophy on minimally invasive valve surgeries.
I think minimally invasive valve surgery is now became a gold standard, exactly as you mentioned. I think it is the difference between Europe and India that in Europe now the robotics in the cardiac surgery has no CE mark at the moment.
Okay.
So I can rely on our experience using the totally endoscopic approach versus direct vision approach. I must say that in many centers in Europe, but almost in every center of Europe, the use of the minimally invasive approach is well accepted. The difference is between whether you do it totally endoscopically or endoscopically assisted, or even using a direct view. And I think these differences are hanging on the type of the valves you operate. If you operate the mitral valve, there's no question that as all around the world, also in our country and also in Europe, the totally endoscopic approach is the most accepted one, and we try to do as many as possible using the totally endoscopic approach regarding the mitral valve. If we talk about the aortic valve, it is another issue, and there are some possibilities, some different approaches. And the right anterior thoracotomy as a gold standard, as you mentioned, became also popular using the endoscopic approach, avoiding the rib spreading, but also moving more lateral and to do an axillary approach without also rib spreading. And with or without the camera assistance, it also became popular in the last several years. So I would advocate this approach. I don't know whether, in your opinion, what is your opinion about these approaches regarding the aortic valve?
So talking about aortic valve, which is a more common valve, and where the minimally invasive approach is becoming a gold standard, mini sternotomy, RATS, right anterior thoracotomy, and axillary. Do you think that, I feel that now there's a time to move towards axillary from the RATS. Does axillary, you think, for both patient point of view and surgeon's point of view, there are more advantages?
I think it is moving to the axillary approach helps you to avoid the use of rib spreading, because moving to the lateral approach, the position of the patient is different. The right arm is hanging, and the third intercostal base instead of the second intercostal, because if you do the right, you do mainly the second. If you do axillary, you do the third intercostal, and the third intercostal base with the proper positioning of the patient is wider. So you have a wider field, you don't have to use the retractor, and I think it is a very important step not to use the retractor to reduce the postoperative pain, because one of our goal is to reduce the postoperative pain using these minimally invasive approaches, and axillary is exactly the way where the postoperative pain can be less than by the anterior approaches.
So you are not injuring the big muscles like the pectorals, you are giving a better cosmetic outcome. And is it also surgeon friendly? Do you think it's a better operation than the RATS?
First of all, you're absolutely right. you can go along the free margin of the pectoral muscle. You can mobilize it a little bit and you can pull it, and you don't have to go through the pectoral muscle. That's point one. That's true. Then cosmetically, because it is lateral, it's invisible from the front. And the third one that you mentioned maybe is also a very important point for the young surgeons and for the bigger part of the surgeons, because the aortic valve is a very common valve. It is a very common operation. It should be a standard operation for every surgeon. And then from this point of view, I think then the axillary approach, it provides you a bit more comfort to operate.
So I understand your point that why there is no CMR yet in Hungary for robotic-assisted cardiac valve surgeries, because anyway you are going to do a mini thoracotomy, and especially if you are going to do endoscopic visualization, then just adding those 3 ports, you are actually injuring more and you are costing more, spending more money.
Yeah.
So I understand and agree with you that the CMR for robotic. The important question now is, everybody is talking about using bioprosthesis, tissue valves. In India, unlike in Europe, we have a lot younger population who requires valve replacement. Now, when we are talking about your philosophy of lifetime management, how young a patient you would be okay to put in a bioprosthesis?
It is a very hot topic, everybody would like to know more about this, and we are discussing it each and every day. The main point is that we have already some long-term results
Evidence.
using bioprosthesis published in the literature, and then there is the so-called this gray zone between 50 and 65 years of age, and this gray zone, our team should decide according to the patient's preference, because that is another question. So in this zone, 50 to 65, patients in Europe, also in Hungary, in our country, just would like to have a normal life, a very active life. The 50 years old generation in Europe is very active, do sport, would like to do their everyday life, and they don't want to be anticoagulated. So what we see, that the patient preference is very, very strong towards the biological valve. So somehow we should accept it, we should discuss it with the patient, but at the end, 9 from 10 patients who come to me to get a valve in the age of 50 or something like that, at the end gets a biological one. That is one. The second point of view that we already talk about, that this operation should be minimally invasive. Because if the first operation is minimally invasive as a gold standard, you can reoperate the patient 10, 15, 18, 19 years later using another minimally invasive approach, let's say the mini sternotomy. You start with the thoracotomy and then you go for a mini sternotomy, and then it's still the risk of reoperation. You may know also from the publication that is also not so high, it's around 2%. So, and after that, is coming another possibility, the valve-in-valve intervention above an age of 70, 75, something like that. And then it is very important of the size of the prosthesis implanted at the first or at the second operation, because the valve-in-valve interventions, it sounds easy or looks easy, but it has many difficulties, and it is not so easy as it looks. It's not desirable.
Like.
Yes.
So it should not be a part of our planning when we plan lifetime.
Yeah, and that's why you should be very careful about this valve-in-valve, I must say. So that is patients above 50. And below 50, our recommendation is still the mechanical prosthesis. But as I said, there are a lot of patients who would like to have a bioprosthesis, and they just sign that they will have another redo operation. And somehow we should accept it. We try to explain the patient the whole perspective of this lifetime management, and if they decide so that they would like to have a bioprosthesis, we go for it. But then minimally invasive and the bigger valve is possible.
In India, what happens is the patients have a lot of belief and trust in doctor, his knowledge and his wisdom. So unlike in the West, what happens in my practice, when a patient comes, he invariably leaves the choice to me, and that becomes a bigger dilemma. So the important thing is not the age, but the longevity, expected longevity, and we go by that. But then comes another question on the lifetime management. Do you want to plan for 2 valves in his life, 3 valves in his life, or 4 valves in his life? I feel that if the patient is going to have a good longevity, which majority of the patients today have, then maybe after 65, till 65 I would put a mechanical valve. After 65 I will put a tissue valve. After that he may come back and get a valve-in-valve TAVI. So he may have just a valve in the lifetime if he's managing an anticoagulation well, or 2 valves in lifetime. But what would be your philosophy on lifetime management, these 2, 3, 4 valves?
Yeah, it's also an interesting question, but let me start with another maybe more important point of view, TAVR or SAVR first, because cardiologists advocate to do in the lifetime management for younger patients TAVR first and then go towards the SAVR. So
how does it make sense?
I don't know. So it's coming from
it doesn't
the
make sense
cardiologist.
to me.
It doesn't make any sense.
Okay.
There are also many, already some, not many, but some publications about it, some data about it, that especially in the US, where they started to implant TAVR for the younger generation as well, and they should be reoperated surgically after that. The results are miserable.
Disastrous.
So it's disastrous.
In an ordinary Joe,
Yeah.
in a surgeon who is an ordinary Joe,
Yeah.
hasn't done much of these, I think the mortality could be far higher than what we see in the literature.
Oh yes, that could be. So that's why I would say no. So as our opinion in our institute, if we do our everyday morning heart team meeting, that always surgical valve first. So this is point 1. Surgical valve first. And then if you have the possibility to make this home management of anticoagulation, so this coagu check possibility to do a blood sample just like as a blood sugar sample and measure the INR, and to if the patient has the possibility at home, we can say that for the younger generation, but that means below 50 in my country. It is so. We can go for a mechanical valve as well.
So another question leading to the same is that in that case, if a patient is younger, insist on a bioprosthesis, would you not like to do a surgical valve replacement first, followed by another surgical valve replacement, because it will not be so difficult, and better keep the transcatheter valve for those who are 75 and above,
Yes.
if their longevity looks good. If the longevity doesn't look good, it's a different subgroup.
I think so. I absolutely agree, and we follow also this way of thinking in my everyday decision making. If we are facing with a failed bioprosthesis, the patient has low risk, we reoperate the patient. It's not a question. That's why it's the biggest role. The first intervention should be done minimally invasive, and we let to do the valve-in-valve intervention only at the very end of the story, and only if it's technically feasible, because so we and you, maybe as you, so we should rely on those cardiology colleagues, experts, whether the valve-in-valve intervention has a low risk or not. They should make a plan about that, and then we discuss it, which way is the best way. But I totally agree with you. This is the same way of thinking, that we let these interventions only for the high-risk patients.
So another last technical question is that in India, I see that 19 millimeter and 21 millimeter, between these two sizes, more than 50% of Indian aortic valve replacements are in this size, which is not a good news for valve-in-valve TAVI when they come in. So what would be your trigger or advice to my fellow surgeons on root widening?
If you use an endoscopic right anterior thoracotomy approach, so everything is possible, but it's not so easy, So to do a root enlargement using this right anterior thoracotomy approach, or even axillary approach, is also feasible. You can do it, but you have only one chance. You do it and that's it. You cannot fix or you can fix, but with a big difficulty. There's some problems that you may
if
have.
you have made a pre-operative decision that
Yes.
I would do a root widening, would you then prefer a mini sternotomy?
That's the point that I would like to point out. We do for each and every patient now, because we moved to the axillary approach. So each and every patient who presented by our cardiologist to have an aortic valve intervention, let's say first intervention, because we decide what type of intervention, should have a CT angio, and we just plan the operation. And if we see that you can measure also for your surgical valve implantation, similar to the TAVR, the annular diameters if you have the CT scan preoperatively. And if you see that the the annulus is a small one, you go for a mini sternotomy. You're absolutely right. It is the same way of thinking. And if the annulus is, let's say, already 19 or 20, you may think about the sutureless valve.
If you are looking at the PPM chart in the OR, and you would rather go by the PPM chart, or you feel that we must put at least 23 millimeter for everybody with the valve in mind in the future,
then we go for a mini sternotomy, at least now, in
but
this moment.
you think 23 should be the desirable size?
It is so. I read also some publications so it published, I think last year, that the trigger that you said at the valve-in-valve intervention should be the 21. So
21.
All of the patients who get a bigger valve than 21, the survival after valve-in-valve is better than patients who has 21 or smaller.
And the structural damage will come much later, little bit.
That's it.
And what is your comment, lastly, on the Boang procedure?
Boang procedure.
Because it looks more promising to give bigger size.
The bigger size valve, yes, but you cannot do it through using a thoracotomy approach.
So it has to be mini
sternotomy, because mini sternotomy is safe for those things. It's very safe for those things.
Very
it's also less invasive, and you can do any type of dental
procedure. You still
procedure.
get the pain advantage and the blood loss advantage. Yes.
But still, the most important is, if we're talking about a, let's say, 72 years old lady, you maybe implant a small valve or sutureless valve or a 90 millimeter valve, and you use any other approach. But for a younger patient, it's better to go for a mini sternotomy, do a root enlargement, and put a bigger valve.
Fantastic. It was a pleasure discussing with you today.
Thank you.
And thank you very much. And I hope you have a good trip in India.
Thank you. Thank you very much. Thank you.